Sir.
Good afternoon, everybody. Thank you, Dr. Rajiv, for allowing me to participate in your beautiful course. Because the cataract surgery, the expectation of patients have increased a lot because of the advancement in the lens quality, premium lenses, and so on. For anything, we need to really not only doing phaco, but then the patient is concerned with the vision, and that is more important for patient. Now, my topic, whatever been assigned to me, is to how to tackle the astigmatic part. 70% of patients have astigmatism, more or less, one diopter or less. And 20 to 30% of patients have cylinder more than one diopter. Astigmatic correction in such cases becomes must, and what are the options? Either you plan your axis incision in such a way that on steep axis particularly, so there's some part of the astigmatism corrected, or you may have to have limber relaxing incisions, or you can have arcuate keratotomy or toric IOLs. Limber relaxing incisions for dummies is there is one nomogram. If it is less than 0.5, up to 0.5, then one incision in a half clock hour you can plan. If it is more than that, 0.75, 2 incisions in 1 clock hour, 1 diopter, 2 incisions in 1.5 clock hours, 1.5 diopter, 2 incisions, and 3 diopter, 2 incisions in 3 o'clock hours. However, a little more for against the rule and for younger patients, and little less for older patients. However, you have to personalize your nomogram. There are various companies, they have their own calculators, and you have to, whichever lens you choose, you have to go for that. My choice, otherwise, normally, because my surgical induced astigmatism is more or less 0.5 the cylinder. So if that up to that cylinder preoperative, I don't treat. And I would wish, on the contrary, that at the end of the day, the patient should have minus half cylinder at 90 degree. So that will give the patient about 6/9 and 8 vision without glasses, even in monofocal lens. If it is more than or equal to 0.75, then I would go for the LRI. But if it is more than 0.75, then toric IOL. There are different markers available for that. And here, either you have to, this is very good markers now we used to do for the PRKs and all, the RKs and all. And then the reference marker with the bubble is more better, so that you can keep the bubble in the horizontal position. And then these are the marker, the ring with the different axis. You can mark it, your plane of axis you can mark, and with this you can mark the pre-existing cylinder axis. Axis mark you can mark on either on the slit lamp with the horizontal slit, and then with this you can see that the horizontal slit is coincide with the marker, the marks. And then there is another method. This is my choice. I do it in the OT only. That patient is made to sit in the and ask the patient to look straight ahead, at a long distance, and then you can, with this bubble marker, you can make these marks. The reference marking, I would be covering a little short about the limbal relaxing incisions. You can see that after marking on the cornea, this is my surgical plane incision, the mark, and then axis. And then this is the marker. One incision you can see here. This must coincide with the cylinder on the cornea. And then there are 8 markers. So one between the two, is 1.5 o'clock. So here I'll be doing, I'm doing two incisions, and between the two incisions. So covering 3 o'clock on either side. But this has to be done on the intact eyeball. That is very important before you start your phaco. There is a patient, female aged 74. Patient wanted to have panoptic toric. The axis is marked, you can see that. The phaco is done. And then you can see here, there's a toric panoptics with the axis marker, the 3 dots. And then, can you go back? बैक नहीं, वो बीच में से आगे वाली वीडियो चलाना है, थोड़ा आगे जाओ, 1 मिनट।
सर लिंक नहीं कर रहा था आपने साहब, ये
क्या हो गया?
लिंक नहीं है सर।
लिंक है? ये स्लाइड बैक जाओ, बैक यहाँ से करो। Okay. Okay. And when the lens is inserted, it is very important that there are 3, in Alcon lenses, no, there are 3 dots. That lens, the dots has to be, they have to be aligned with your original, the marking on the cornea. It is very important. You must make it proper. Here, there is another type of lens, size lens. You can see here, this is my case, where I already marked it 110 degree, and then the axis is marked, and after the cataract extraction and everything, the lens has to be placed in the bag, and then you can see, this is wide lens. It is a small little, not dots, but the line, so that is easy. You can, again, you have to be very careful that the lines are coincide with the marking of the cornea. In my case, in our series now, the most important is the toric lenses. The average was -2 cylinder. It ranged from 0.79 to 4.16. And post-operative it was -0.15 cylinder. The range was 0.75 to +1. And multifocal toric, average was -1.52 cylinder. It ranged from -0.85 to -2.71. And the average landing was -0.5 cylinder. The range was 0 to -1.5 cylinder. Thank you very much.
Thank you, Dr. Shroff.
Any question?
Anybody? We can have the discussion later on. Anybody wants to add something, or Vijay kuch?
I would like to add one more.
Yeah, sure.
Two couple of sentences. In spite of all efforts, everything, at the end of the day, it is a possibility you will end up with the astigmatism. And everything, your closest case now. So in my hand, couple of cases, we have gone for laser refractive surgery. And that gives excellent result. Of course, you cannot charge this patient, or you already charged. But then that is the best option. Thank you.
Is that counseling is very important?
Very important, yes, sir. And particularly for the premium lenses, very, very important.